One of the nice things about COS is we're still kind of small. We're hoping to be bigger, but when someone has a great idea, there's a good chance it's going to stick. And so I was pleased to see Nathan Henson up there. He's been a longtime member of COS. He's an active long-term missionary down in Peru, but he served on the board and had a great idea. He asked himself, what are we doing as a society, as excited as we are and as much as we individually participate, what are we doing as a society corporately to aid missions in the name of the gospel? And so Nathan came up with the concept of foster a missionary, where we have the opportunity as a group to focus our efforts, focus our idea, and hopefully at the end of the day have something tangible that we can reflect back on and see God's goodness through us corporately throughout the greater world. So that's what the Foster a Missionary program is all about. We're on our, third generation now, and so Wendy is here. She was our first recipient of the Foster a Missionary program. Joan Pons was number 2, and particularly with Wendy, I remember that she had already been on the field for a while. She was doing great work with some pretty rotten equipment. And that was kind of the focus, was how can we assist her and aid her to do top-notch care with the top-notch skills that she has, and just enable her, enable someone who already has boots on the ground and already is there offering herself or himself and just knows what needs to be done. And so to enable them and to bring what we have to the table. So this past year, if you were at COS last summer, we introduced John Cropsey as our third generation recipient for FAM. So he's been with us for a year now, but we have another year to go. So we're kind of in the halfway point here. We look forward to hearing from John this afternoon to hear how it's going and what big ideas God is bringing to him.
All right, I've spoken at universities, churches, but never in a zoo. So put on your pith hats, helmets, whatever they are, and hopefully my computer works seamlessly.
Also in an aquarium.
Yeah, or an aquarium. I've also not given a talk in an aquarium. Come on. All right. Kind of, maybe not. Yeah, we're getting closer. All right. Great. So we're going to go on an adventure, a safari, so to speak, to the Central Highlands of Africa. All right. So this is right on the edge, actually, of Akagera Park in Rwanda, where we went camping not too long ago. And this is the amazing country I currently live in. And I want to tell you a little bit about what's going on in Rwanda with a foster a missionary program in our family. Many of you are familiar with us, but not everyone, so I'll give you a little bit of background in my financial disclosures. So I work for Surge Global. I'll tell you a little bit more about them as a full-time missionary. The Foster a Missionary program, per Jeff tells me this morning, that so far you guys have raised $121,000 as a society. That's amazing. Thank you. Yeah, thank you so much for your generosity. That's incredible. I also want to acknowledge sitting with us here today is Jeff Tabin from Cure Blindness. Jeff has been a good friend. Did we meet at COS or I think we might have, or at Will's, but anyways, maybe back in 2007 or so, 2008. Wow. I met Jeff at COS, and he has been a huge mentor to me, an encouragement to me. In the last year, Cure Blindness supported us to deliver just shy of 6,000 cataract surgeries in Eastern Congo, which had a war going on and now has Ebola, which you'll hear about shortly, in Burundi. And so, Jeff, you funded us for $5,000 and we gave you almost $6,000. And we still had some money left over. And then this year, just recently, right as Ebola was breaking, Samaritan's Purse partnered with our Congolese teams to do our first partner camp where they funded it, but we fully ran it as I Love Africa. And right after we left the camp literally the next day we found out we did it in the middle of an Ebola epidemic. But God spared our team, and no one got Ebola on the I team. So where in the world is Rwanda? For those of you who don't know your African geography, it is the heart of Africa. There it is, a tiny little country, but densely populated, the most densely populated country, about 14 to 15 million people. Oops, and that's my family. Let me tell you about my family. So my wife, Jessica, and then our oldest is Elise. She is now back in the US, about to start university at a little school in Indiana called Taylor. And she has a passion for working with vulnerable women coming out of difficult situations. So that's what she's going to be pursuing, and she'd like to be back overseas someday soon. And then Micah, he is 17. He is going to be a senior at Rift Valley Academy, so he's in Kenya. And then our son Sam, 14, is with us in Rwanda. And so 3 kids, 3 countries. So we're trying to figure that out. Jessica sits on the board of Sam's school and also helps do some remedial math teaching in another school in Kigali. And she also helps at the residency program you're going to hear more about as our academic officer, helping us get organized. And she does a whole lot of other stuff. So blessed for that. So Surge, why would our mission be named Surge? So Surge comes from a sewing term. Actually, I didn't know this until I learned more, but it's a machine that joins together rough edges to form a smooth seam. And so our mission, we see God weaving together our own weakness and frayed edges of our tattered world and his goodness, creating something beautiful. It's here we see God, it's here we see his grace at the fray in our life and in our work. So our objectives today, we had to get CME credit, had to have some objectives here. So we're going to look at what we do. We're going to look at the eye care needs in what we call the Great Lakes region of Africa. Just like we have the Great Lakes in North America, we have massive lakes in Africa, which is, they're really amazing. We heard a little bit yesterday about what cataract surgical rate means. I'm going to also talk a little bit about effective cataract surgical rate. And then we'll update you on what we're trying to do to create sustainable eye care through a social enterprise model, and update you guys on what the foster program is doing with us. All right, so like I said, we're full-time missionaries with Surge. We're based in Kigali, Rwanda, but we do work also in Burundi and Eastern Congo. Jessica and I are the regional supervisors for Democratic Republic of Congo and Uganda as well. So that takes up a little bit of our time. And then under our mission, we run the I Love Africa project. And our main partner in Rwanda is the Rwanda International Institute of Ophthalmology, which was founded by 2 incredible Africans that Jeff Tabin knows well, actually. John Nudukie, he's a war hero from around the time of the Rwandan genocide. He has an incredible story, then became a cornea surgeon, in large part thanks to Jeff. And he just became the past president of COEXA, the College of Ophthalmology of Eastern, Central, and Southern Africa. He served 2 terms and it termed out. And then his wife is Chiku Matenge, who is an incredible doctor. She is an MD, PhD, giant brain, fireball, and she is the current president of the African Council of Ophthalmology, which is meeting in Cape Town, South Africa right now. So I'm missing out on Cape Town, guys, to be here. But yeah, so two incredible leaders in ophthalmology in Africa, and I get to work with them every day. All right, so our mission's kind of vision statement is laying down our lives for the world's good and God's glory. And a lot of you have asked me about Ebola, and this ties in with this statement right here. All right, so as some of you know, there's an Ebola outbreak happening in Eastern Congo right now, right on the border with Rwanda. And our mission happens to work in 2 mission hospitals right in the middle of that outbreak. And interestingly, our mission seems to attract Ebola. I don't know what's going on. So our first experience with Ebola actually was in Bundabugyo, which is The name of one of the 3 strains of Ebola is named after where our mission worked, in this tiny outpost on the edge of Congo in western Uganda. And so my current bosses, Dr. Scott and Jennifer Myrie, were there. And sadly, some of the first people to die in the outbreak were eye care providers, because it can present as hemorrhagic conjunctivitis, and they didn't know it was Ebola at the time. And so they lost one of their key eye care personnel in that outbreak. Scott and Jennifer, if I remember the story right, were both exposed and had to isolate and send their kids out of the country without them at the time. Then Scott in 2014, because he had so much experience with Ebola, he volunteered and went to Liberia to serve in that outbreak in 2014. Then in 2018, Patrick La Rochelle was working in Ituri province, where the current outbreak is, at Nyankunde Mission Hospital, and was exposed before they knew it was Ebola. And he evacuated to Goma and stayed with our I Love Africa partner, Jason Patua, who you'll hear about more. Jason kept him in his house, in a room on the side, until he could get evacuated. So Jason's got a big heart. And guess where he came? Right here to Omaha. Yesterday we got an incredible tour of your facility, of your holographic studio and stuff, and a big part of that building was the biocontainment issue that we didn't get to see it, but and so this is one of the world's most advanced biocontainment units right here in Omaha, Nebraska. Then we got our own hemorrhagic fever in Rwanda in 2024. Had to cancel coming to the academy because of it. And Marburg is like Ebola on steroids. It's like previously 80% fatal. Rwanda did a great job, and it was only 20% fatal this time. And then in May 2026, Jeff, I was at Paul Farmer's hospital in Butaro at University of Global Health Equity doing a cataract camp. And I get a phone call from, guess who, Patrick La Rochelle, the guy from before. And he says, they just said we have Ebola, and I probably am exposed, and I'm about to get on an airplane. Should I get on or not with his family? He was heading to the meeting that I was going to too in Spain in a couple days. And I'm like, yeah, you probably shouldn't get on that airplane if you've been exposed to Ebola and spread it into Europe. So they stayed behind. And then shortly after, his compatriots at the mission hospital next door with our mission, Dr. Peter Stafford, also, then the CDC met with all our doctors, and he had a clear exposure, and his wife, who's OB-GYN, he's a surgeon, she's an OB-GYN surgeon. They both were exposed. They have 4 little kids, and they're in the middle of nowhere in eastern Congo. And so anyways, the next 72 hours of my life was trying to learn how you work through the CDC and the higher powers to get people evacuated when they've been exposed to Ebola. Shortly after Peter said he thought he was exposed, the next morning he became symptomatic and had to stay in his house. Imagine this. You're in your house, your wife and kids are outside, and they can't come in and help you. No one can come in because there's not the proper PPE, and he's just getting sicker and sicker and sicker. So it's pretty scary, pretty frightening. And as I told you, our I team just left the area right before that. So this is Peter and his family. So Peter fell ill. He was starting to get delirious, and no one could really go in and help. But eventually, they decided they had to go in and give him an IV. So one brave Congolese healthcare worker put on the PPE they had and got him an IV started until he could get evacuated. He had to get transported in this ambulance from a rural mission hospital to Bunia, where there's an airport. And there's special airplanes. There's only a few in the world that can handle a biocontainment active Ebola case. So they had to fly a smaller one in to Bunia on the smaller strip, get him to Uganda, where there's a bigger strip, to get him on a bigger plane that could get him to Europe. So this is, he then gets put in a pod and put on this plane, and then safely got to Berlin, where they took care of him there. And then Patrick, good old Patrick, the one who was exposed in 2018, second exposure. We didn't have to have quite the level of care because he didn't have Ebola yet, but he had to go to Prague by the same bio evac flight. And he was put in a plastic bubble for 21 days in Prague. And so took it like a champ, no running water, no shower for 21 days. But hey, he survived, and he's happy to be out of quarantine. So when Peter got to the airport, they shut down the Autobahn in Berlin. And there was like 32 vehicle caravan to the hospital. So pretty crazy stuff. So anyways, all that to say, Ebola, you can really pray for Eastern Congo right now. This outbreak is going to be very terrible. Eastern Congo, like just in Ituri province, I think there's like 50 different rebel groups. Each little area is controlled by a different rebel group. It is incredibly challenging to provide healthcare in this context. There's no trust. Given 30 years of conflict between like the UN, World Health Organization, and the local population, it's really challenging. And so the case rate is going through the roof. I think there's just, the latest numbers are about 1,300 deaths, many more exposures, and that's the tip of the iceberg because they can't even do very much testing because of the instability. So Eastern Congo needs our prayers. Eastern Congo is densely populated, and it sits right on the border with Uganda, which has had 27 cases from some spillover. And Rwanda sits on the border. And so you can pray stays where it is and that progress starts getting made. You can pray a vaccine will be developed against the Bundibugyo variant because the current one is only against the Zaire variant. So all that to say, that's my other hat, non-iCare. All right, so I Love Africa is our project with iCare, and so our little mantra is pretty simple. Train, mentor, equip. Training, teaching someone to fish. Mentoring, I liken it to teaching someone where to fish, all right? And equipping, getting them a fishing pole, making sure they can do what they're trained to do. All right, so training, what does that look like? That's mainly done here at the Rwanda International Institute of Ophthalmology. Here's some of our residents. And let's see, Rebecca is right there in the middle. She's now at Tenwick, working where Ben Roberts and Sam Powdrill were for many years. And she's a superstar. She's doing a great job. And so Rio's purpose is to support and positively influence eye care, education, service delivery, and research in order to transform our trainees and our communities. We do that through education, community engagement, research, and improving ourselves regularly. So this is Rio in Kigali. My picture cut off a little bit for some reason. So we've got all 3 floors of the hospital except the little other pharmacy on the bottom floor there. And in there we have a private clinic and also the nonprofits housed there. This is our public clinic where we partner with the government and run their major district hospital, and that's where our main resident clinic is housed. So just some pictures of our residents learning how to do indirect ophthalmoscopy with their arc lights. And we got the chance with Orbis to play around with the IC last summer, which was pretty fun. And our residency is the first in the region to be a private residency, not under a university or under the government. So we're completely independent. Also means we get no funding outside of whatever we find ourselves. But we've been accredited by COEXA, the first to ever be accredited by COEXA, and we're the first in Africa to be given advanced accreditation by the Ophthalmology Foundation. All right, so that's training. You guys get it. We all went through residency training. So mentoring, this is something we touched on yesterday. How do you get people who have the skill and the knowledge to go where they're needed most? And this is where mentorship really comes in. And there's nothing better than doing what you say you should do, right? And so in Burundi, we lived in a rural place in Burundi, kind of probably like where you were in Borneo. Like Burundian doctors would come out here and to us and be like, what are you doing out here? Why would you live here? And so even as our medical students trained, they caught a vision for what they could do. And so a fun story for time. I don't want to keep the kids from the zoo. We're trying to wrap up by 3. It's already 3, I think. So I'll speed things up here, but this is a fun story. Clarice was my medical student in Burundi. She and a group of students came out and were blown away serving in rural Africa as medical students and saw this group of American doctors living in rural Africa. And a group of them committed to kind of doing the same thing. She's now working as a general surgeon in Togo, West Africa, in northern Togo, at a hospital my dad started. So that's pretty cool, how it came full circle. So this is what mentorship looks like. When you mentor people and you live it out yourself, they see that and it really impacts people. And she's doing amazing work there. So this is a group of our residents. My mom passed away in February, and these are all the eye care professionals in Kigali, including our residents, but even beyond that, coming to give their respects. And Jeff, you'll notice the Cure Blindness team was actually there that night and came and joined us, which was really special. So so this is us being loved on by our African brothers and sisters. But one way we mentor is by inviting people into our house. So every other Friday, we try to have the residents and whoever else wants to join us, completely voluntary, but we sit down and we look at what it looks like to follow Jesus and be an ophthalmologist, for example. So we look through the compassion of Jesus and the themes we saw were that Jesus would see people. Like when you look at the stories of Jesus in the Bible, in his healings, it always says he looked at somebody, he was moved by compassion, and then he acted, right? And so we kind of work through that together. How do we see the people sitting in front of us, let God work in our hearts, and then do something to help those people? All right, this is my son Micah. We were out at Kibagora Mission Hospital doing a cataract outreach just before Christmas. This place is stunningly beautiful on Lake Kivu. And I just saw this lady coming up the hill, up this steep hill in a wheelchair, and I said, let me just. I grabbed my phone and started videotaping her because I thought it might be an interesting story. We had already started screening. And so here she comes. Super steep hill. It's steeper than it looks. So, all right, she works her way up this crazy steep hill. We get a look at her. So here she is. She's with her adult daughter in her 40s. And then we look in her eye. I just shined my light in her eye, and she had this beautiful smile. You'll notice she's missing one eye. She lost one eye as a kid in a trauma. And then we look in her other eye, and she's got this cataract. She'd been blind for 36 years before the Rwandan genocide. I don't even know how she survived the genocide blind. And she hadn't seen her daughter since her daughter was 7 years old. But she had this amazing joy about her, even though she was blind and withered up and old. So anyways, she reminded me of the Sermon on the Mount. So seeing the crowds, Jesus went up on the mountain, and when he sat down, his disciples came to him. And he opened his mouth and taught them, saying, "Blessed are the poor in spirit, for theirs is the kingdom of heaven. Blessed are those who mourn, for they shall be comforted. Blessed are the meek, for they shall inherit the earth. Blessed are those who hunger and thirst for righteousness, for they shall be satisfied. Blessed are the merciful, for they shall receive mercy." You know, Jesus taught us that the world's upside down. This little old lady in God's kingdom, she's the queen. You know, we've been given our affluence and our power and our good life now. People like her are gonna reign. So. You know, these are the people we want to kiss up to, not presidents and politicians. The little old ladies who are widows sitting blind, these are the people you want to kiss up to right now. So anyways, I don't have time to tell her. She has an amazing story. But people sometimes ask me if I'm fluent in Kinyarwanda. I want you to look at this ambulance sitting at the hospital we were at. And I dare anyone to try to say the word ambulance in Kinyarwanda. Okay? That's the word for ambulance. No, I'm not fluent in Kinyarwanda. I know some French, but man, Kinyarwanda is a butt kicker. It took a miracle for this lady to get to the hospital, I'll just say that. She lost her ID papers in the genocide and was never able to become to get the papers she needed to get health care. So anyways, so this is her on the table. My son had to lift her out of the wheelchair and lay her on the table. And there's her whopper of a cataract. And here she is the next day. And her daughter is on the right there. She hadn't seen her, like I said, since she was 7 years old. And here are everyone celebrating for her. That's her daughter in the middle. And the other postdocs. Shake that IOL, baby. Shake it. Yeah, so, another person we're mentoring, right, is our kids. And so it's so special to be able to have my kids see this kind of stuff and see what the world's really about. So here's Micah with her. It's raining pretty hard at that point. And then, again, we're there with our trainees. They're getting to see this. They're out in their own country, seeing the need in their own country. And that's inspiring them to go and do likewise. All right. For the sake of time, I'm gonna breeze through this. Ben, we had the chance to do Bible story training with George Mixon with a bunch of the I folks just last month, and that was a blast. So these are all of our partners in Burundi. Here they are, practicing. So training and then the mentoring part is critical, I think, to accomplish the mission of curing the blind in these rural, hard to get to places. But you can do all that, and like Wendy, you can be in the middle of the jungle and have bad equipment, and it can be really tough to deliver the quality of care you want to. And so equipping, getting them high quality fishing poles isn't cheap in ophthalmology. And so how do we do that? So after a better part of 2 decades in Africa, and in our part of Africa where there's just so much conflict and mistrust, doing like big glamorous things doesn't work very well because people don't work well together in general. They mistrust each other. So we're trying to do more grassroots individual empowerment. And so this is a little bit of what that looks like in Eastern Congo. So here's Africa, population density map here. You can see the highlands of Ethiopia, and then these Great Lakes of Africa. See Lake Victoria and around that. Densely populated, the Niger Delta, et cetera. So this is where a lot of people live, and there's actually a lot of conflict right in this area. And so Rwanda is down into the left above Burundi there. And so over the years living in this part of Africa, I've had the honor of training and partnering with, I think, about 38 ophthalmologists. And so these are the people we're trying to empower. And you can see where they're all located right now. So Jeff Amos is coming to us. You're sponsoring him, by the way, from South Sudan. We have got 3 people actually coming all the way from the Bahamas. Surprisingly, the Bahamas has very poor public eye care. And so we're working with their government to provide eye care to the public in the Bahamas. And then all around this area, we're just able to really empower so many ophthalmologists. All the people in red are still in training. We have 17 ophthalmologists in training. We've graduated 13 already in the last 4 years. And the ones in black are people we partner with, but I didn't specifically necessarily train. But like JC, we helped him do a vitreoretinal fellowship. He's the only one in Burundi doing VR and retinoblastoma. Patrick, we sent to Erevan to do oculoplastics and ocular oncology. And Adrienne did a glaucoma fellowship in Burundi. So we're kind of trying to build up those fellowship level trainees. So we think partnering with Cure Blindness, the I Love Africa team was, we believe, the 2nd largest contributor to the cataract surgical rate in Congo last year. Actually, I think we might be the first, because when we calculated that number last summer when I was here, we still did a couple thousand more. And I think the other leader was like 5,000 something, and we did almost 6,000. So we might. So this little ragtag group went into that crazy place. They would have to like negotiate with like rebel leaders. Can we come and do a screening in your like territory? And they'd have to agree and provide security. So these guys are heroes. These guys are incredible. But we don't just care about doing surgery, right? We care about quality, right? Steve, care about quality, all right? So quality drives development, as Glenn Strauss taught me, all right? You have to deliver quality to develop eye care. And so a big part of getting grants and things is data reporting. And that's really helped our ophthalmologists look at their quality, because they have to look at their outcomes. And so we track all of our outreach cataracts, day 1, week 1, month 1, looking at refractive outcome, IOP, obviously vision, et cetera. So that's really improved each of our partners' quality. So looking at kind of a social enterprise model, my good friend Dan Kiage, who some of you know, he stole this from someone, but he couldn't remember who. But he says it's the 3 M's. And so you want your eye care professionals in charge of the 3 M's: the money, the materials, and the manpower. And a lot of times I think we get in frustrating situations when the eye care professionals don't control those things, and you end up spinning your wheels a lot. So just as you engage with different things, think about that as you go out on mission, and who you're empowering and how you're empowering. Are you empowering yourself? Or are you putting it in the hands of the people on the ground who need to really control these things to do things properly? Obviously, it takes trust to do that. But if you find the right people, this is really important. All right. So we've done this in Kigali, where we helped invest in the private clinic. And now the nonprofit part of our work, Rio, the nonprofit, the school, and our outreach stuff, is a shareholder in the private clinic. So now when our private clinic becomes profitable, it'll create revenue for the nonprofit. We're just breaking even now in the private clinic after about 4 years. So soon, hopefully, we'll be creating actual revenue for the nonprofit side. And so then they don't have to raise money for that, right? That's just like profit for the future. We're doing the same thing in Goma with Edvision. Goma is a city of 2 million people. And Jason, until our graduate just joined him, was the only surgical ophthalmologist in Goma. And there's actually money in Goma, but it all leaves for Nairobi or the Europe or the US. When you need a cataract surgery, you leave. All right, so how do we help these guys keep this? So Jason also has his private practice, and then Edvision is the nonprofit, and we did the same thing. We put an OCT into Blue Rock Optical, his for-profit clinic. And I'll show you kind of how that works here in just a second. And then we're doing the same thing with Tony. We're going to start the first eye clinic in the whole province of Tanganyika province. It's the size of England. And he's the first and only ophthalmologist there. And there's no eye clinic. So part of what we're going to try to do this year is get him a shipment of eye equipment to launch the first eye clinic there. And then we have 6 partners in Burundi where we're piloting some financing for outreach for them, and we created an app so they can report their data in an app, so we can do better and easier reporting. So this is kind of our core I Love Africa team. We have 2 ophthalmic clinical officers who work full-time for I Love Africa, and then 2 what we call holistic eye care specialists. You can kind of think of, they take care of logistics, patients, lodging, transport, food, and then they sit down with each patient and hear their story and listen to them and hear what's happened to them. Going blind, as you heard in Africa, you can get kicked out of your village. It's brutal what these patients go through when they go blind in Africa. As Jeff taught us yesterday, your life expectancy can drop by 1/3 or more when you go blind in these places. It's brutal. So we have 2 people just there for a kind of psychosocial and spiritual support of these patients, and it's beautiful to see the work they get to do. And then we got a bunch of ophthalmologists. I showed this last year, but these are the conditions they're going to get to these places to do their outreach camps. So Stan's microscope, Stan, Sam, iMobile microscope on the back of the motorcycle there going through a flooded road. All right, so what are we doing? What are we trialing here? So I Love Africa with particular partners that we have a high level of trust with. We're investing 75% into, for example, an OCT machine or a phaco. And then our partner is putting in 25%. So a brand new Phaco, it's like over $40,000. So 25% of that's nothing to scoff at. They're going to cherish this machine. They're going to treat it like their firstborn child, because that child isn't going to eat if it doesn't work. So our partners put in 25%, and then their sweat equity, we give them another 13%, and then we'll give them a no interest loan for another 13% that they have to pay off when they become profitable. Then that gives them the majority share in the machine, or whatever it is we're doing together. I Love Africa will retain 49%. So we're the minority shareholder because I don't want to run and operate their business. Then what we're going to do is hopefully we can generate personal income. Like Jason's been serving in Goma for like 15 something years. I don't know the exact number, but probably about that. He doesn't own a home. He's an ophthalmologist, right? He's got 4 kids, and he's adopted a kid in his family that lost their mother. And he doesn't own a home. And he stayed there because he's super committed. Like, how do we help these people earn a real living? And so part of that, hopefully, will grow personal income for people like Jason, and then give them capital to reinvest in their own businesses. All right? And then ours will go to support things that don't make money, like holistic care. All right? It'll go towards InReach, so they can care for poor patients when they show up at their clinics, and they can subsidize their care. And then it'll pay for their outreach that they're already doing, but we're fully funding to get them out there. And so then this will break the cycle of forever fundraising to make these things more operational and keep them very missional focused and outward focused. So that's our goal. And it's starting to work, I think, but time will tell. All right. The other thing we do, though, I think everyone needs to be aware of when you do like free mission, it can be really devastating to the local eye care community, okay? So let's say this is someone's eye clinic. When we support them to care for the poor, we basically say, if you take care of a poor person at your clinic, we want you to use a sliding scale on how much you help them. We do not want you to do free, unless they're like, abjectly poor, okay? And so we won't subsidize them for the same amount to do a cataract surgery if they're near their base, which we just kind of arbitrarily made 100 kilometers radius, all right? But if they go out beyond their catchment area to a place where that can't get to them or any other decent eye care, then we'll be more open to like fully funding a cataract surgery. So just as you go into communities, you always need to work with local eye care professionals to really understand. You can put someone out of business. Imagine they've invested everything to get their clinic running, and then you come in and do a free eye camp. People will wait years waiting for another free eye camp and not go to the existing ophthalmologist because they're like, maybe they'll come again and I don't have to pay. So it's a mindset that can be very detrimental to sustainable eye care. So just something to think about. Always partner with locals and understand your impact on the existing infrastructure, because you might actually be undermining it. All right. So update on where we're at. So training 17 residents, some things, I saw Jeff and I have been racking our brains. How do we get a good teaching microscope for these outreaches? Because these outreaches are super critical training opportunities. And like the mobile scopes just aren't perfect for training. Lo and behold, we saw iMobile's got an incredible heads-up display now. There's goggles. What is it, Ingenuity in the US? I don't even know. Stan's now got a device in Stan that you just take off your head of your microscope and pop this sucker around there, and now everyone just wears a headset, and you don't even have to be right at the head of the table. You don't have to crink your neck, and you can do surgery. And you can have 2 heads. There's a splitter, and so I can teach someone and see in 3D. So I think that could be a game changer. So I think that could be great for teaching residents on outreach. So equipment already purchased with the help from the partnership. We've bought multiple B scans, indirects, portable slit lamps for our mobile teams. And like I talked about, we put an OCT into Goma, the first in Eastern Congo. This OCT is amazing. It's from Poland, from Optopol. It does optical biometry, topography, fundus photography, angiography, and every OCT you could want. Anterior segment, posterior segment. So it's like, so many machines in one, so that saves you so much clinic space. and brings down the price of the equipment, even though it's still $65,000, but it's locally maintained and cared for by Dr. Kibata's group, who is based in Nairobi. All right, and then we just put a FACO into Goma to create revenue. All right, for Dr. Tony in Tanganyika, like I said, we want to launch the first eye clinic in his province, and so we're hoping to put together a shipping container. So Samaritan's Purse has offered warehouse space for us to store donated equipment in a climatized situation until we can fill up a container and ship it to him. So if you have equipment, someone who's retiring and it's not working out to, I don't know, those old slit lamps and stuff are actually workhorses. But we don't want junk for Jesus. We want good stuff. So we don't want your trash. We want really well-running quality equipment. But if you have that, please get in touch and we'll put it to good use. Yeah. And then, like I said, we have 6 pilot partners in Burundi where we've developed an app where we're going to do some microfinancing so they can care for poor patients in their practices throughout Burundi, and we'll see how that goes. And then we'll scale it up if we can, if it works well. All right. And then we want to equip 2 more outreach teams in DRC with surgical microscopes, biometry, et cetera. All right, and then exciting news, we have a team from COS coming to visit us in Rwanda in September. So we're looking forward to that. And then we're in the early stages of something called the Barnabas Project, where Stan and others, it's not like a super formed idea, but there's 38 young ophthalmologists who would love to have a mentor. And you don't even have to necessarily go there. Some of these places you can't go. But even by email, Zoom, you could be a great encouragement to somebody. And so if you're interested in being a mentor to one of these guys or anyone in the world, talk to Stan or myself, and we'll try to connect you with somebody, all right? And don't want to keep you too much longer. There's a world-class zoo waiting for you, and I've already gone over. But as you can see, the work we get to do is a huge honor and a blessing. This is our team at a district hospital in rural Rwanda after finishing a camp. And yeah, thank you so much for your support. It's an honor to work with you guys and to be blessed by you guys. And my wife, I've never been on social media. Probably going to keep it that way. But if you are, my wife tries to keep up a bit of an Instagram and Facebook feed on I Love Africa. So you can just put that in there and find us. I can't tell you more than that. And then she also made this QR code, which you can scan. And if you want to get quarterly email updates, you're welcome to do that. You can just scan that code and put your email in there. And try to quarterly try to get you an update. All right. Happy to stick around for questions, but I also don't want to keep you from the zoo. So do you want to take any questions, or you can just come up here and talk to me, I think, if you have a question. So.
Thank you, John. Certainly one of my heroes. Able to hear big ideas from God and somehow able to put them into action. As we wrap up here, we have an opportunity. As we said, we're halfway through supporting John through the FAM. He and his family. They are done their support raising. They've already gone and talked and knocked on all the doors so that they can be there in that place. But we have an opportunity as a society to latch on to these bigger ideas and to support those and to claim them in some small way as our own. And so as I cover 3 little points here, it's all covered with go home and pray how God would lead you in your finances. But out of compassion for me and for you, I would encourage everyone in this room in some way to grab a piece of what John is doing financially to support him. And after a year of time and the door closes for this opportunity, you can sit back in your heart and say, I took part of that. And I think you'll be rewarded for that. in any way that you participate. Number two, many of us are blessed to be in the U.S. and to be blessed financially with our own work. And I would encourage you to pray through what does that mean? What does that opportunity give? We all do things, I'm sure, in this room individually. And so this is just adding to what your opportunities are. But as we are able to earn a living off of what we do, that is not always to increase our standard of living, as one of my partners says back home, Dr. Heitman, but it can serve to increase our standard of giving. So take that to heart, pray about that. And then for those of you who are maybe a little further along in your career, who may be sitting at the table when your business makes decisions, just like we are coming together as a society, how do you come together as a business and think about what you do, not as an individual doctor and go home and do your things privately, but how do you control and strap on to that business model and incorporate giving, incorporate missions in your own entity and business? Think about the individual parts of your practice, whether you're doing injections or selling premium IOLs or fancy glasses. Just how can you section out part of that and say, this is for God? As a group, we're going to come together and maybe participate in FAM for now, but even in your own community in other ways. I would encourage you in that from a larger business model. How can you do that? So please go home and pray about that. We have a wonderful opportunity to continue supporting John and these big ideas that he's doing. And we look forward to hearing from him next year. Hopefully we'll find him wherever he is in the world to come back and tell us how he's doing. Thank you guys so much.